Good afternoon, and thank you for joining us. My name is Tracy Davis, and I am the coordinator for the Physical and Mental Health Subcommittee of Program Planning and Development with Suburban Houston Fort Bend Alumni Chapter of Delta Sigma Theta Sorority Incorporated. We're excited that you've joined us for today's event. Before we get started, I would like to make everyone aware that all participants are currently muted, also known as listen-only mode. Today's event is streaming live on Facebook, and we invite you to visit our page at Suburban Houston Fort Bend Alumni Chapter and use the reactions and/or share button to invite others to join today's wonderful program. Throughout today's event, if you have any questions or comments, you can type them in the Q&A box in the webinar or the comments section on Facebook Live. Someone from our team or the panelists will either reply back to you or answer your questions live. Again, thank you for joining us.
Good afternoon. My name is Lena Ellis, and I'm the second vice president of the Suburban Houston Fort Bend Alumni Chapter of Delta Sigma Theta Sorority Incorporated. This week is Black Maternal Health Week, highlighting the disparities in health outcomes for pregnant people. Black mothers are 2 to 3 times more likely to die from pregnancy-related complications than their white counterparts. In 2021, the White House began recognizing Black Maternal Health Week, and in a proclamation that was released here recently on April the 8th of 2022, President Biden and Vice President Kamala Harris renewed their commitment to addressing the crisis of Black maternal mortality and morbidity across our country. Aligned with Delta Sigma Theta's programmatic thrust for physical and mental health and political awareness and involvement through social action, we are committed to continuing the efforts that address the disproportionate health disparities amongst women of color and understanding ways that we can further expand better maternal care. The goal of today's presentation is to share innovative insights that will help bolster community programs, train public health and healthcare providers, enhance research, and ensure maternal care is coordinated better. On behalf of the Suburban Houston Fort Bend Alumni Chapter, we thank you for joining us today with our presenters. Before we get started, I did want to recognize that we have joining with us a little later today, State Representative Sean Terry, who represents the District 146. This covers numerous counties within the southwest and southeast parts of Houston. We invited Representative Terry to be here with us today so she can briefly share her continued passion to be an advocate at the state level that pursues policies that will reduce pregnancy-related morbidity and mortalities and increase patient outreach and education for healthcare providers. Once Representative Terry does join us, we will have her come back on and give us a couple of additional insights.
Hello, my name is Courtney Harris. Sorry, I do have a last minute guest with me for today. But I am a member of the Physical and Mental Health Subcommittee, and I will be introducing our first speaker today, Dr. Carissa Tucker. She is a postdoctoral fellow in the lab of Dr. Susan Carmichael. Her research interests are centered around maternal health equity, social detriments of health and severe maternal morbidity. Dr. Tucker has over 10 years of experience as a labor and delivery nurse. She has also taught nursing students for 5 years. She received her PhD in nursing science, where her dissertation used medical expenditure panel survey data to examine the impact of patient-centered medical homes and personally mediated racism measures on severe maternal morbidity outcomes. She has also published a literature review on group prenatal care and maternal outcomes. Dr. Tucker, go ahead, it's your floor.
Hello, everyone, and thank you for having me here today. Again, as Courtney stated, I am Dr. Carissa Tucker, postdoctoral scholar, currently at Stanford University School of Medicine. The objectives today for my presentation are to describe the current rates and disparities in maternal outcomes in the US and briefly introduce my program of research. So starting off with the background, as we've all heard throughout the media, and on the news, maternal health outcomes are the worst for racial and ethnic minority patients here in the US. Even though we are one of the most developed and industrialized countries in the world, the US unfortunately has some of the worst rates. There are disparities in pregnancy-related death and severe maternal morbidities where Black women suffer the most disparate outcomes. Here is a graph from the Centers for Disease Control and Prevention, available on their website. They started measuring pregnancy-related deaths in the late 80s. And at that time, they were measuring about between 7 and 8 deaths per 100,000 live births. As you can see from this graph, all the way up through 2017, the number has pretty much doubled, over doubled in these years that they've been measuring it. So as of 2017, there are approximately 17 deaths per 100,000 live births. A pregnancy-related death is a rare event. However, is an event, a tragic event that should never happen to any woman. This is also a graph from the CDC showing the different causes of pregnancy-related death. As you see from the bar graph here, indicating which causes or per year. These are the top causes that they've measured that are related to the pregnancy-related deaths. So back in the early 80s, from 87 through 90, the most common cause of pregnancy-related death was hemorrhage. And then we move on to the red graph, or the red bars, from 1991 to 2000. I'm sorry, go back. From 1991 to 20, back. Thank you. From 91 to 97, the highest rates of death were still hemorrhage, but then you also start to see hypertensive disorders, so like your preeclampsia and eclampsia. The most recent years, they've measured between 2011 to 2013, the highest rates of death are cardiovascular related. Next slide, please. So this is a graph again from the CDC showing the disparity ratios, or racial and ethnic disparities, from 2014 to 2017. Non-Hispanic white women have a 13.4 per 100,000 live births rate of pregnancy-related death. However, as you see on the far left, minorities like non-Hispanic Black women, we have 41.7 pregnancy-related deaths per 100,000 live births. Next is non-Hispanic Native American or Alaska Native patients, then Asian Pacific Islanders, and then lowest rates would be Hispanic. This is also an unfortunate statistic to report. Again, no one should have a pregnancy-related death, but as we see, there's a huge disparity gap for Black women. Next slide. All right, so closely related to pregnancy-related death is a severe maternal morbidity, or a near miss. So the CDC classifies or identifies 21 indicators or types of severe maternal morbidities. A severe maternal morbidity is an event that could have resulted in a death, or a tragic event that happened during labor and birth, etc. Examples of a severe maternal morbidity would be like anemia, aneurysm, myocardial infarction, sepsis, etc. Again, there's 21 different indicators, and they're all available on the CDC's website. It's also been found from maternal mortality review committees throughout the US. There was a report published in 2018 that 63% of all pregnancy-related deaths are preventable, and these preventable deaths are attributable to provider negligence, patient not knowing when they should alert the provider, etc. But the fact that 63% of all of these deaths are preventable is something that should be addressed. Next slide. So this is a graph showing the trend of severe maternal morbidities. If you put pregnancy-related death and compare it to SMM, or severe maternal morbidities, you see the same trend line, okay? Severe maternal morbidities are things that could have resulted in a death, a near miss. So the orange line is the overall rate of severe maternal morbidity with blood transfusions. And as we see, again, from the early 90s to 2014, the number is severely increasing, Okay, they're measuring this per 10,000 delivery hospitalizations. The next line is with blood transfusions, the blue line. And then the green line is SMM without blood transfusions. But again, the overall rate is tremendous, over 140 SMMs per 10,000 delivery hospitalizations. Next slide. This is a graph representing the proportion of severe maternal morbidity by timing of pregnancy across racial groups. Okay, so the blue bars are indicating the antepartum period. Orange bars, delivery period. Gray bars is the postpartum period, and yellow is more so overall. Again, what do we see? A huge disparity gap between Black women and all other racial groups. And what's very apparent to me is that SMMs mostly occur during the antepartum period. So while the woman is still pregnant, okay? Next slide, please. This is a graph representing the US infant mortality rate by race and ethnicity. So as we see with pregnancy-related death, unfortunately, infant mortality is also mostly affected or impacted in the Black community or minority community as well. There are 10.8 infant mortality deaths per 1,000 live births for non-Hispanic Black women. And then the next highest would be Native Hawaiian or Pacific Islander, then American Indian, then Hispanic, and the lowest groups would be non-Hispanic, White, and Asian. This again comes from the CDC. This is the national measure of infant mortality. So many or a lot of the recent work being done in this area of social justice or reproductive justice is indicating that racism may be a cause, healthcare provider bias, etc. There are 3 different types of racism. I'm naming 2 here. There's institutionalized or structural racism, defined as having less availability of opportunities and resources by race. This is the assumption that the institutional racism can lead to less access and lower quality maternal care for racial and ethnic minorities. There's also personally mediated racism, which is defined as prejudice and discrimination. Prejudice occurs when assumptions about a person are made based on their race, and discrimination exists when someone is treated differently based on their race. And the last one that I haven't mentioned here is personally perceived racism, where people of a racial group believe the negative stereotypes of their identified race. These different definitions of racism were coined by Kamara P. Jones back in 2000, and she created a theoretical framework on this. So unfortunately, many of these outcomes, disparate outcomes for minority groups, especially Black women, are tied to a person named J. Marion Sims, who is one of the first gynecologists back from slavery times, and he's known as the father of gynecology. This is a graphical picture or depiction of him doing some experimental work on a slave that he owned named Anarcha. She was 17 years old, and basically research has shown and it's been documented that he did experiments on her, like things like repair of her perineum. He would intentionally injure it and then repair it back because of the belief that Black people or slaves did not experience pain. And so this was definitely one of the most tragic examples that we see in our history, but it shows that, the ties to racism and how the negative beliefs that Black people don't experience pain, etc., have all affected outcomes, not only in maternal health, but outcomes for health in general for the Black population in the US. Again, she was only 17, so she was a child. And he did all of these experiments on her with no anesthesia. So in his practices with this, he basically was performing these experiments to perfect his craft. And this is unfortunate. So this first picture on the right was put together by the March of Dimes. The graph of the US is basically a graph depicting maternal health, maternity care deserts in the US. Okay, so basically everything in the red is showing a county in the US that does not have access to an OB care provider. Okay, and I don't know about you, but this is a ton of many counties in the US that do not have adequate access for maternity care. And people who live in rural areas have to drive hours sometimes to actually go to see a healthcare provider and deliver a baby. On the left are two examples of people who have experiences with obstetric racism. On the left at the top is a patient who died. I'm from South Carolina. Her story was published in the news, but her name is Yolanda Minchin. I think it was back in 2016, she delivered her baby, went home, had a lot of headaches, started having a lot of blurry vision, went to the emergency room. They took her blood pressure. It was like 200 over 100, skyrocketed, very high. She was in the ER for approximately 6 hours, no medication, and she eventually died. Okay, again, she was in the ER and she died in their care because of lack of adequate care, appropriateness, and concern for her condition. On the bottom right, everyone knows Serena Williams. She described in a magazine a couple years ago when she delivered her baby that she has a history with blood clots. When she delivered, after delivery, she started feeling really weird, chest heaviness, told the nurses on staff that, she wasn't feeling well. The nurses told her basically, oh, that's normal, you just delivered, et cetera, kind of, trying to minimize her situation. She demanded that they do something. She demanded that they check her, and they ended up doing a scan and they found some PEs in her body. So she could have died. Thank goodness she didn't. She advocated for herself and got care. So again, bias, not listening to patients. A lot of minority women, Black women are saying that healthcare providers do not listen to them. And it's unfortunate. One of the things that I have published in my doctoral program was a literature review on group prenatal care. Group prenatal care, or centering pregnancy, is a type of care where women come in as groups of 8 to 10, 12 or so, have their vital signs done, labs done as a group, come in and sit down with a healthcare provider, and they have that group dynamic to where they can ask questions, receive care all at the same time. It's been reported that they feel more comfortable with their providers, and being around other patients because they all have a common theme, and they're able to have that shared experience. So my goal with this group literature review, scoping review that I published in the American Journal of Maternal Child Nursing last year was basically to see what outcomes are reported for women. Group prenatal care has been linked to having positive outcomes for like reducing preterm birth and positive outcomes for infants. But next slide, please. What I found, definitely that there's inconclusive evidence on the amount of studies that are showing how group prenatal care, the results can impact women. So definitely more studies need to be done on this. And there is indication that group prenatal care is positive for our maternal patients. Next, please. One of the other studies that I have in progress is using medical expenditures panel survey data with the AHRQ, which is a publicly accessible data set that asks, it's a survey basically for patients asking about their experiences with healthcare providers. Next. And one of my current projects is looking at the postpartum readmissions. Next, please. So why is postpartum readmission important? An important indicator of healthcare quality is hospital readmission rates, which reflects quality of care and impacts hospital reimbursements. Centers for Medicare and Medicaid Services considers about 63% of all hospital readmissions preventable. And a PPR, or postpartum readmission, reflects the sickness of maternal patients and can be considered a sentinel event that puts a significant strain on the mother and family. Next, please. So what I want to find out, I'm using California-based hospital data, vital records linked to discharge data from 1997 to 2020. This is over 10 million births in this data set. But basically, I want to know, increase the understanding of the trends of disparities for postpartum readmissions. I'm basically doing a temporal analysis of the postpartum readmission rate and looking at the racial and ethnic disparities for all racial groups. And my second study is looking at the contribution of neighborhood social disadvantage to postpartum readmissions. So neighborhood social disadvantage is basically a social determinant of health measure, looking at the context of income levels, education rates, employment levels in the area where the patients live, and how it impacts maternal outcomes. So this is preliminary results from my postpartum readmission study. Basically, from 97 to 2018, the top line in this graph is showing the Black race, non-Hispanic Black women. The blue line is non-Hispanic white. As we can see, again, there's an unfortunate disparity here where more Black women are basically 2 times more likely to have a postpartum readmission. And I'm looking at the readmission rate within 42 days, which is a typical 6 weeks recovery period. Next, please. All right. Thank you for listening to my presentation, and I'll take questions now or at the end.
Excuse me. Thank you so much, Dr. Tucker, for your presentation. We definitely enjoyed hearing your insights for today. Right now, we don't see any questions in the chat, but if they do come up in the questions and answers portion, we will be sure to get those questions to get answered to you. Right now, we do have Representative Sean Terry, who has joined us. And we would, as we mentioned a little earlier, we're definitely interested in hearing her insights with regards to all of her advocacy that she has been doing at the state level for Black women with maternal health. Representative Terry, I'll turn it over.
Good morning. Good morning, everyone. Well, good afternoon, should I say, everyone. How are you? Thank you very much for having me today. Everything you just heard is all of what we're working on at the state level, and specifically with regard to the disparities. And so I wanted to talk a little bit about the legislation that I've filed, that I've been carrying session after session to try to move the ball down the field, as well as just my own personal experience in this area. Just like Serena Williams, I too almost lost my life in childbirth. Just one moment, you all, let me fix my screen. 1 second. Just 1 second. Just give me one moment. Got you. Okay, sorry about that. So one of the things I wanted to start with was where our doctor left off, which is directly related to the implicit bias, which is what we're hearing no matter whether you're in a top tier income, whether you have private health care, whether you're on Medicaid. Black women across the country are being treated in a disparate way. I filed legislation last session, and I will be carrying it again this session, which will require, for the first time in Texas, healthcare providers, medical doctors to take courses in cultural competency and implicit bias. Just as you've heard, lots of these viewpoints are long-held subtle beliefs. We've heard about the study where they conducted an interview of University of Virginia medical students who actually believed that Black women's skin is thicker, not in the colloquial sense, not figuratively, but literally thicker than everyone else's skin. Therefore, they said they would poke them harder with needles. They would also believe that we heard about slavery, that as the descendants of slaves, that our pain threshold is somehow higher. Therefore, if you look at the data, it shows that African Americans end up waiting in the ER much longer, and they are slower to receive proper pain management. So all of these things are affecting women in the maternal health care space. So by requiring our medical providers to at least take their courses in cultural competency and implicit bias, I'm very confident that that would at least help eliminate this going forward. Also in Texas, we have an immense data backlog. As grim as the statistics are that we're hearing for Texas, which is that Black women are 3 times more likely to die in childbirth and that the majority of those deaths are preventable, I want to be candid with you all. We are still looking at data from 2010, 2012, 2014. By the time we really start to implement some meaningful policies, the data will be over a decade old. So I've also filed a legislation to create the first statewide maternal care data registry. It would operate in real time. The state of California has done this. And what it would do is healthcare providers would be able to input everything about a woman's health, maternal health. For example, if she was hemorrhaging, if she died of a hemorrhage, if it was the result of a C-section gone wrong, we would have that information stored in one central location so that we can look at it in real time and not be playing such a catch-up game. Right now, even if the governor of Texas wanted to go pull significant data, the data we're looking at is very, very old. So without current data, it's very, very hard for us to really know exactly what we're dealing with. And then one of the things I really wanted to share with you, which has just kind of been the impetus for my work in this space. And I share the story because I want people to realize that it can happen to anyone. My daughter is now 9, but when I was carrying her, when I went into labor, I had proper health care, wasn't a state rep at the time, still I'd been a practicing attorney for 20 years and had full coverage. When I went in, it turned out that I was going to go ahead and get a C-section. I ended up on the table, and right before they were about to, start the procedure, I'd received my epidural, and I felt immediately like something was wrong. I wasn't nervous. I wasn't having any kind of panic attack because I was ready to rock and roll. It was my first baby, only baby. I had no really qualms about it. All of a sudden, I started to tell the nurses and the doctors in the room that I was in a lot of pain. And they said, that's impossible. You can't feel anything. And I said, no, something is wrong. I said, my legs are throbbing. They're stinging, they're burning. And I said, my chest is hurting really bad. Physically, like my heart, my chest is hurting. So they just kept saying, no, just, kind of patting my hand. And so finally, I started to lie there. And after about 2 minutes, I realized, I was like, I'm not going to make it. I think I'm dying. My heart started to beat like it was going to burst out of my chest. It was very difficult for me to breathe. On top of that, as I said, my legs felt like thousands of bees were stinging me all at the same time. So I started to scream and tell everyone, help me, please listen to me. I'm telling you, I'm in extreme pain. I can't breathe. So they were all just kind of looking around, and finally, I don't know, by the grace of God, there go I started to remember that when people are in extreme pain, the body sometimes will shut down as a defense mechanism and faint. I've never fainted in my life, and I must not be capable of it, but I wanted to mimic that. And I asked them to put me under full anesthesia. I started screaming, put me under, put me under. And they just kind of looked around and said, well, we have to go get your doctor to do that. He wasn't even in the room. So I said, hurry, hurry. So they ran to get him. I guess they got the okay. And the next thing I remember, they were putting something over my face. And when I woke up, ladies, and if there are any male allies listening, everyone was just, I was in another room and everyone was just standing around looking kind of dumbfounded. And a nurse said, I'm sorry. And I was like, oh my God, I burst into tears. I thought I'd lost my baby. And then I started crying. She said, oh, no, I'm just sorry. What happened? And I said, well, what's going on? We're going to try to have the baby deliver or clear. And they said, oh, you had the baby. I was like, what? So they did the C-section in that process, but it was a very negative birth experience for me. Only child I'm ever going to have. And I have no recollection of having a baby. But what I found out later is that's a very specific problem. It's called high block epidural. The epidural had been put up too high in my spine. So instead of numbing my lower half of my body, it was numbing my heart, my upper body. And that's why my heart was doing that and I couldn't breathe. And it can be fatal. And the only treatment I found out, ladies, for that, I talked to a number of anesthesiologists, one of them who actually works in the House of Representatives with me, is going under anesthesia. So can you believe, just like Serena Williams, I don't know if it's something about Black women, how we know to just push. Had I not said that, I very likely would not be here with you today. And there may have been another infant mortality. I don't know if my daughter would have survived. And I really, from, that, even from that moment, I looked at the fact that I was, at least, just like Serena, I was able to convince them to do it. But imagine if I had been one of these young ladies that maybe they already came in and had a bias and said, well, she's on Medicaid. Oh, this is her fifth baby. She doesn't need any more children. Who's to say they would have really listened to me?
Yeah.
I did mention, they knew. Now, I don't know if I just kind of threw this out there, but when I was making the chit chat with them right before the epidural, I mentioned that I was an attorney and probably just as a lawyer, we know to do that sometimes. So maybe that a little bit worked in my favor, but I'll tell you the last part of the story that made it all really pouring salt in my wounds. When my OBGYN came in to the room later that day, actually it was the next day, he didn't even come see me. He walked into the hospital room. After everything I had gone through, he walked right in and he said, hey, crazy lady, I heard you went crazy in there on the table. I mean, y'all, it makes me tear up thinking about it. Can you imagine speaking to me that way after everything that happened? And now I come to find out it obviously wasn't my fault. But he was always that kind of a doctor. And so one of the things I think that when we do these type of events and town halls, I always encourage women, if you're not comfortable, find another doctor. If your doctor is not treating you with respect and care and compassion, find somewhere else. If you go to another one and you don't like that one, find another one, because that is the worst thing. And I should have done that. When I went to that doctor, he was highly recommended and a long waiting list, but it was almost like cattle in there. When you go in the room, you're just waiting for a number. He pushed right through me. Even when he told me I was having a girl, he clicked on the sonogram and I was all excited. And he said, head, shoulders, you see that? Nothing in between. He was talking about the legs and he clicked the camera off. He said, buy something pink, and just turned it off. And I said, what? I said, can I see again? What are you saying? So that was his way of telling me it's a girl, but he did it all in 4 seconds and then turned the machine off. And it was time for me to go. So I always, look at that and say, if this happened to me as a Black woman, and I should have had what they would say, all the things that would have allowed me to have excellent healthcare in this country. We know that it's happening on a massive scale. And the other piece of data I wanted to share is that, and you may have heard this, but when I first started following my legislation, one of the things I did in 2017, I wrote to the governor and asked him to put this issue on the special session call. And I was very blessed that I'm the only Democrat, even in that contentious year where everybody was divided. I was the only one that he agreed that he would put this issue and look at it further. But I wanted to look at the socioeconomic ramifications of this. And what the bombshell was that even a Black woman who has a degree, who has healthcare, even if she is similarly situated with her white counterpart, same health risk, same weight, maybe non-diabetic, all of the same factors being equal, she is still 3 times more likely to die in childbirth than her white counterpart who may be on Medicaid, who doesn't have an education, what have you. They look at these social determinants of health because they tend to say, well, the more educated you are, maybe you did better prenatal care, maybe you took better care of yourself. But even when we have done everything right and followed by the textbook, our outcomes are still abysmal. So this is why I'm going to continue to file more and more legislation. I invite you all to always leave with a call of action. One of the most important things you can do is show up. When we have these hearings at the Capitol, well, we're kind of in a COVID world right now, but now that things will be back to normal next session, come down or register in favor of the bill. Come down and testify in favor of it. Many times when I go in those committees, I look around and there's not enough of us. So it'll just be me advocating to the chair of the committee and the members on the Public Health Committee that this work is so important for Black women. But when I turn around and I look out there, there's not enough of us there or any of our allies there to support the work. I've been fortunate to have created a lot of awareness on this issue and to be able to get some legislation passed. But as you've heard today, there is so much more to be done. And I'm here for questions as well. I just wanted to give you some context for why I work in this space and the kind of work that I'm doing.
Thank you, Representative Thierry, for sharing your courageous story, for the call of action, and your wonderful efforts to bring focused attention and awareness to implicit bias. Thank you so much. I will now introduce our next speakers, Dr. Judy Levison and Marilyn Yvette Peters. Dr. Judy Levison is a professor in the Department of Obstetrics and Gynecology at Baylor College of Medicine in Houston, Texas. She completed her MD degree from Tufts University in Boston, her residency in OB/GYN at the University of Washington, and her Master of Public Health from the University of Texas of Public Health in 2010. She was in private practice in the Seattle area, and for 14 years, she was in private practice in Seattle for 14 years and spent 4 years on the OB/GYN faculty at Stanford University Medical Center at Santa Clara Valley Medical Center in California. Since 2002, she has led the Harris Health System Women's Program, which provides obstetric and gynecologic care for women living with HIV in Houston, Texas. She is active in educating Texas healthcare workers about the management of HIV. She teaches medical students and residents in her clinics and at Ben Taub General Hospital. She is on the National Perinatal Guidelines Panel and provides consultation for the National Perinatal Hotline. Her work in the area of HIV has led her consult on projects in Swaziland, Namibia, Ukraine, Dominican Republic, Honduras, Nepal, and Malawi. Her group is first in the United States to develop a curriculum for group perinatal care for women living with HIV and to follow the outcomes of this program. Next, we have Nurse Marilyn Yvette Peters. She received her BS in nursing from Tuskegee University and her Master's of Sciences in Nursing, nurse practitioner from the University of Florida at Jacksonville. Nurse Peters has been a nurse practitioner with Harris Health System for 22 years. Ladies, you have the floor.
Thank you so much, Tracy. And just so that we can time this appropriately, am I correct? We have about 20 minutes?
Yes, ma'am.
Okay, so we may just we may move through some things a little bit quickly. So our overarching objectives are to help future healthcare providers understand that they can enter the care paradigm and impact disproportionate health outcomes for African American women. Why don't you go ahead? I think we all know we're really here to deal with social determinants of health. And specifically, by the end, I hope you can state factors affecting perinatal HIV transmission, describe what is meant by U equals U, define what is meant by PrEP, and describe some innovative ways to address barriers to care. And I think I'm going to skip over this in the name of time, and this is just to let you know that there are some newer ways to do HIV testing. And just briefly, that the older tests were antibody tests that took anywhere from 6 weeks to 3 months to show up. And so if somebody was concerned about having had maybe an HIV exposure, they often were told to come back and let's retest you in 6 weeks, let's retest you in 3 months. The test now will pick up HIV within 2 weeks of exposure. Thanks. And just very relevant to our work, since 2006, CDC has recommended HIV testing at a first prenatal visit and in high-risk jurisdictions like Texas in the 3rd trimester, ideally at around 36 weeks gestation. Expedited testing, meaning results available very rapidly in labor and delivery, are recommended if we don't have a 3rd trimester test. In Harris Health, we are doing it at all 3 time points. And this is something just that what comes to mind after hearing Sean Theory speak is that up until 2010, Texas was testing early and in labor and delivery. And what we were seeing is there were a number of women who were missed because there was no 3rd trimester testing done. And we worked with the legislature, and the law got changed in 2010. So just some basics on HIV transmission. There's about a 25% risk of transmission to the baby if there is no treatment in pregnancy. And that's how it was until the mid-1990s. But if a woman is diagnosed and treated in pregnancy, there's a less than 1% risk of transmission. And specifically, if someone is living with HIV, is on medication, and has what we call an undetectable viral load prior to pregnancy, during pregnancy, and at delivery, among 2,600 mother-baby pairs who met those criteria, there were 0 transmissions. So we are really at a place where we think we could get very close to 0, but we're not there yet. And I just also want to address some of the artwork that you're seeing, like this, was done by middle schoolers. There is an art program in Houston for middle schoolers and for HIV, for AIDS Awareness Day, early December. There's a competition and they do artwork. So these are 11 to 13-year-olds who are tasked with doing artwork related to HIV. And it means they have to research information about HIV and AIDS. And I think they've come up with some of the most powerful messages, and I have their permission to use their artwork in my talks. In 1990, there were 2,000 babies born with HIV, and by 2017, it was down to 39. And so on one hand, it seems like, oh, not that many. But the minute we turn our heads away, you know it's going to climb. And of course, Florida, Texas, Georgia, Louisiana, and Maryland accounted for almost 40% of the new cases of HIV in the United States. And for those of you who are in the medical nursing realm, I want you to know about 2 amazing resources for if you have questions. And these are for clinicians at 3 in the morning. The National Perinatal Hotline. There are clinicians available 24/7. And so a woman is newly diagnosed with HIV at 3 in the morning, clinician can call the hotline and say, what do I do now? The other are the perinatal HIV guidelines, and these are updated annually to keep up with the latest information in the care of pregnant women with HIV. And this is a phone number I wish every clinician had in their phone, the 888-448-8765. That is the National Perinatal HIV Hotline. I want it on every labor and delivery. Other things you need to know, that just here's some things that have changed over time. Once upon a time, you had to take a handful of pills. If you had HIV, that's changed quite a bit. And I'm going to explain briefly about U equals U in PrEP. So we're now down to most people are taking one pill or maybe two small pills daily, usually once a day, whereas 20 years ago, it might have been a handful of pills 3 times a day. And then something that really has been a game changer is U equals U. And what that means is if you have an undetectable viral load, so viral load is refers to the test that checks how many little bits of virus in a teaspoon of blood. Our goal is undetectable. And what we now know is that if you have an undetectable viral load, you cannot give HIV to a sexual partner. And as we saw, you also can't give it to your baby during pregnancy. And what has really made a difference for a lot of women in terms of their own self-perception is, it used to be if you wanted to tell a partner, I have HIV, it could be a really scary moment. And not knowing, is this partner going to hang around or not? Now you can say that I have HIV, but I can't give it to you. And that really changes the conversation. PrEP is referring to pre-exposure prophylaxis. This is medication that an individual can take to prevent themselves from getting HIV. It is certainly very popular in the men having sex with men community, and I think women sometimes underestimate their need for it. Go ahead. And I think that, clinicians and women underestimate their own risk. And women, we certainly, among many of our patients, the women themselves had no personal risks. They're monogamous, they're married, they're mothers of 2 and 3, but their partners may be bringing risks to the relationship. So should we be offering PrEP to all sexually active women? And I mean, this is really more, this is not there's a single right answer to this, but if a woman has a sexually transmitted infection like gonorrhea or chlamydia, we really should be thinking about, one, testing for other sexually transmitted infections like HIV and syphilis. And if we're thinking about that, we should be offering PrEP. If a woman has an abnormal pap, which is caused by human papillomavirus, which is sexually transmitted, we probably should be thinking about offering PrEP. If a woman comes to discuss contraception, she's having sex, we should think about offering PrEP. And if a woman is pregnant, she's had exposure to semen, most often via condomless sex, should we be offering PrEP? Does she know her partner's HIV status? So Yvette is going to talk a little about how we have been implementing changes to deal with some of these issues.
Hi, everybody. Thank you so much, Lena, and all my sorors on the call. And I want to talk about the new approaches that we've done. I was so excited to hear Dr. Tucker talk about group prenatal care, because this is one of the new things that we've started in our clinic actually about 8 years ago. So this is actually a picture of our site at Northwest Clinic off of 610. And our group prenatal classes are held in group sessions in waiting rooms that's similar to the one that you see here. So I'll talk a little bit about that, as well as our state prenatal infant morbidity review of syphilis and HIV that we participate in. Next slide. So as you can see with the graphic that's on your screen here, there are some challenges when you care for women with HIV. And you see in these concentric circles, some of the top challenges, number one being well-educated about HIV itself. The second concentric circle to the right is helping women to overcome the stigma and shame that's associated with HIV. because we all know that we've heard, I think when we first had HIV presented to us in the United States, we thought of HIV as a gay white male disease, but what we quickly learned is that HIV is a sexually transmitted disease, and if any person has had sex, you could have been exposed to it. So becoming well educated also can help reduce some of the stigma and shame that's associated with it. And in doing so, we feel like a person, whoever it is, would be more empowered to move on with life. And one of the quotes that we got from one of our patients is what's listed here, is that HIV then is a small piece of the pie of their life. And the second biggest issue is for women to stay in care once they've had their baby after delivery. Next slide. So when we looked at the group prenatal centering pregnancy, you see the two columns here. We wanted just to point out the difference in the centering group and the one-on-one care. So with centering, we have a set of topics that are all related to pregnancy as well as HIV. And when you compare that to the one-on-one traditional care, there's very little uniformity in terms of what gets offered each visit. And Dr. Levison and myself were keenly made aware of that when we first went to training for centering. For centering, there are 10 two-hour sessions, which equals about 20 hours that you're in contact with a patient in total in front of a clinician, as well as the ladies get to be with each other. One of the things that we found early on before we started centering was that the ladies were sitting in the waiting room and they were having conversations. Sometimes we had moms there that had had babies with us before and were previously diagnosed. We would have women in the waiting room that had not been diagnosed prior to this pregnancy, and they were communicating. So having that information up front, we really felt like centering would be a good fit for us, and we moved forward with trying to learn more about it. And when you look at the one-on-one care, you usually have 10 minutes if you have that. The clinician is usually with you a total of about 2.5 hours during your entire pregnancy, versus you really getting to know your patient in a group setting when you have 20 hours together. The next line is 2-hour sessions filled with, like I said, if you're looking at the pregnancy side, we cover things like early signs and symptoms of pregnancy. We cover things like postpartum depression. And what we know from the one-on-one contact is most of the time you are sitting in the waiting room, you may be there not having any information provided, and it's just kind of lapse or wasted time. Like I said, each session is 2 hours, and our centering sessions are geared full of information and sometimes even fun things. When we try to talk about our different topics, we do it in a very fun way. One of the things we do is we play a game like charades when we talk about the discomforts in pregnancy, just to kind of make it a fun activity and for our women to learn as well. So they play charades and we kind of talk about, have you ever had, fatigue? And then to do the charades thing, you act out fatigue, you act out the shortness of breath, and the ladies get to learn as well as to have fun. Next slide. So we saw previous deficiencies in our care, and we came up with 10 related topics that we wanted to be sure we covered in each session. The first one, often we were not getting to topics that we knew we wanted to cover. Without going through the progress note, it was very difficult to go back and see if every single pregnant woman that we took care of got the same message. So oftentimes when you come in for a one-on-one visit, is geared to one particular topic, but we were never sure that everybody got everything. So that's how we decided to come up with the 10 topics that we wanted to cover. Next slide. So 10 topics specifically for pregnancy, and then 10 topics specifically related to HIV. We wanted to be sure our women had experience with the diagnosis. We wanted to be sure they had information on disclosure to partners, family, and friend. We wanted to be sure they really understood what HIV is. We wanted to make sure that our women understood how the medications work, the importance of adherence to the medication. Once you start medication, even if it's during pregnancy, you're basically going to be on medicine for the rest of your life. And what we've learned, even outside of pregnancy, is many times people will start the HIV medications, but they don't remain on medicine. And as Dr. Levison just mentioned, that puts the community at risk if you're HIV positive and you're not on medication. So we wanted to be sure that the ladies that were within our care understood the importance of both of those. The next thing we wanted to be sure was how long can a woman expect to live? You know, to get this diagnosis, it's very traumatizing. And that's one of the most important things that come up. How long am I going to live? And what we're pleased to say is that we think of HIV now as a chronic disease. It's no longer an acute disease. And what that means is we manage HIV just as we would someone that has hypertension. You've got to take your blood pressure medicine, because if you don't, there are some long-term health risks that you would face. Same as if you're diabetic. If you're diabetic and you're not diet controlled, or you don't stay on your oral medicine or your insulin, there are some serious health consequences that come along with that. So we think of HIV as we would a chronic disease. If you take your medicine, we expect for you to be able to live your normal course of life. The last bullet there is, what is the risk to my baby being born with HIV, and if the mother is taking medication? So we make sure that the mom understands that if she's on her meds during pregnancy, the risk, as Dr. Levison mentioned, is less than 1% that your baby will be HIV positive. And we do expect for you to have a negative baby and you to continue to live your life. Next slide. Some other topics that often come up, the women have questions about vaginal deliveries versus C-sections. If a mom is undetectable, that particular number happens to be less than 1,000 copies of HIV in your blood, she can expect to have a vaginal delivery unless there's an obstetrical problem that has nothing to do with HIV that causes her to have a C-section. Safe sex and safe contraception, including what Dr. Levison just mentioned, PrEP, and having a negative HIV partner. The importance of the logistics of staying in care after delivery, I just alluded to, and babies are always tested and followed by the pediatric ID for up to 18 months. Next slide. So our data looking back for the first 8 years of our group prenatal care, looking at pre and post survey of knowledge, attitude, adherence, depression, and stigma. The findings we found were women had lower levels of depression and lack of adherence due to depression after attending the centering sessions. And women who went through centering had lower viral loads at delivery and 1 year after delivery than those that did not attend the centering sessions. Next slide. So I wanted to leave you with, because some quotes I'll say from some of the ladies that have gone through the groups, and we thought these quotes were very, very powerful, as you can read them on the screen. I have a couple of favorites on here. One woman said, "I don't feel judged when I'm here in the centering classes." They felt like they would now had a community that they could identify with. They felt very grateful to feel like they were normal. We try very, very hard to normalize this happy time in a woman's life to have this diagnosis, and we want them to know that our life will still continue to go on. One other one over here that I really liked is, I thought I knew more about it, but I've learned so much more since I've been here. So it's an ongoing learning experience for them. And they can take that journey with us and with the women that they meet that happen to be pregnant at the same time and pretty close to the same time in gestation. And then there's the last one that says, the group gave me not only physical, but also emotional and spiritual support. When I first found out I had HIV, I was ready to wipe my hands across my head and neck, meaning I wanted to kill myself. Now I know I can live, and And now I know I can live and be there for my family and my children. So this is just an example of some of the quotations after each centering session that we asked the ladies to share with us what the experience was like. And these are some of their quotes. And is there one more slide, Lena? Yeah. So the next thing I really want to share with you right quickly is our fetal infant morbidity review of HIV and syphilis. This is a statewide program that we participate in where we're reviewing cases of babies born with HIV and syphilis across the state. This review includes a maternal review of the mother because we're very interested in talking to her to find out just what her knowledge was during her pregnancy. How much did she really know about being screened for syphilis and the possibility of getting syphilis or HIV during pregnancy? So we'd like to listen to her and see what she felt like her experience was. Our FEMA group is actually a community group. We have physicians that take care of women that are HIV positive. We have pediatric doctors that are a part of the group. We have social workers that are part of the group. We have nurses. We have workers from the city of Houston that do the epidemiology and the direct contact. So we all meet on a quarterly basis and review these cases. And our challenge is to give a review and to summarize barriers to care with the purpose of trying to reach out to institutions that are capable and willing to make changes to prevent these things from happening. Next slide. So basically, FEMA risk goes from the micro, which would be the patient, to the macro, which would be the larger system as a whole, where we try to provide support and to provide maybe some assistance in removing some of those barriers, I'm sorry. Next slide, I think is the last one. And I want to thank you for the opportunity to share some new approaches in pregnancy centering. Thank you for your questions.
Thank you so much, Nurse Peters. We really appreciate your presentation. We had questions that did come up in the chat, and we'll ask it to one of our presenters to see if perhaps one of you all would like to answer that question. The question we received on the Facebook Live was, how do you educate our partners and families and friends how to be advocates for us? And I think this was coming from a perspective as a Black woman that's carrying a child. How do we educate our partners and families and friends to advocate for us?
Lena, this is Yvette. I think the most important part is for us to let our clients know that they are worthy and to be willing to just speak. Not to remain silent. No question is a stupid question. You should always be in an environment where you're comfortable with asking a question. And like the representative said earlier, if you're not in that type of environment, you need to find a new doctor, but you're worthy. Ask the question and keep asking the question. Keep asking the question. Show up and keep asking, I think.
Yeah, and I think we tell our women, if there's anything that anyone is suggesting, when you're in the hospital, for example, and you don't understand it or you don't feel comfortable with it, it's fine to speak up and ask questions and say, well, wait, why are you doing this? And, and so I think often the physicians are willing to do it, but they sometimes just sort of are moving so quickly that they don't realize they haven't explained it. So yes, speak up whenever you want to.
And I would add to that, yeah, in regards to the partners know and family members know their family member the most. So if they think there's something odd or off about them, definitely let the provider know. And I'm not sure if anyone's ever heard of Charles Johnson. He's from California. His wife unfortunately died. He started a foundation called Four Cures for Moms. She died at Cedars-Sinai after a hemorrhage from a C-section. And he goes around the country talking about his story about how he tried to alert the doctors and let them know that the blood in her catheter bag was not normal. and that information about his story is published online, but he's made it a mission to educate other people and partners about his story and advocating for their patients. Charles Johnson, FYI, is Judge Hatchett's son or son-in-law. So yeah, it's definitely his home for a lot of people.
Yes. And we did get one comment in the chat that I want to share with the entire group. It says, thank you all for your work that you're doing to bring awareness to this topic. This has been an excellent presentation. Dr. Levinson, it is great to get an update on the work that you and your team are continuing to do at Northwest. The contributions you have made to the care of women with HIV, especially those from underserved backgrounds, is outstanding. We are fortunate to have you at Baylor College of Medicine, and I can personally echo those sentiments and thank both you and Nurse Peters for all of the work that you all have done, and especially bringing, this very interesting research with centering pregnancy in this high-risk population. So again, we applaud you and thank you for all of your work.
Thanks so much.
Yeah.
Lena, we actually have some questions from the chat, several questions. For the group prenatal programs, is this readily recommended by physicians? Are there Spanish-speaking groups or Spanish-speaking group prenatal facilitators?
So centering is, it's actually available nationally. What we did was adapted for HIV, but the hub for it it's called Centering Healthcare Institute in Boston, and they provide training and materials to back up a program. We do our groups in English and Spanish. We have both. I speak enough Spanish to get by, and we also have a research coordinator who is a native Spanish speaker. So between the two of us, we will, if we have Spanish speakers, we just go back and forth throughout during the group. But yeah, definitely. And we have the materials are available in Spanish too.
Thank you so much for that information. We do have another question. It looks like this may be geared towards Representative Terry, but our fellow panelists, our other panelists or speakers, you all may have information. How do we know when there is maternal health legislation so we can provide support in person? Not sure if any of you all may stay abreast to the legislation. I know you all are busy with your work and your research. Let's see.
I know at a national level, I guess Lauren Underwood, she publishes a lot of things that she's doing with like the Momnibus bill. So on the national level, and then she puts a lot of things out there on Twitter. So maybe follow her. She's a representative. Sorry.
No problem. And I was going to mention, we can definitely follow up with Representative Terry and send out a follow-up communication. And on our Facebook comments, we'll add the chat and the response to the question to share with the entire group, because that's an excellent question as well. And Ms. Courtney, are there any other questions in the chat or from our Facebook group that we want to address with our panelists? Oh, thank you. Someone did put in the chat, which we'll share as well. There's a bill tracker that we can follow, and it allows you to search by term each one of those bills. So if there is a particular bill that you're interested in learning additional information on, we'll put that in the chat here in a moment as well for you all to see, and you can track those bills in that way as well. So again, on behalf of our chapter president, Jackie Smith, and our chapter, we really want to thank our panelists for their contributions today and taking the time to provide their wonderful insights and raise awareness surrounding the state of Black maternal health in the United States and understanding the consequences of systemic discrimination, recognizing the scope of the problem and the need for the urgent solution that we need to amplify our voices as Black women in our community. I'll turn it over to our coordinator, Tracy Davis, to conclude our presentation for today.
As Lena mentioned, this concludes our event today. As a reminder, a brief survey will be shared within 48 hours of the event. Please take time to share your feedback with us. We'd love to hear from you. Please feel free to join us as we sing together for a few minutes as we conclude. For those who are joining us on Facebook Live or watching the recording, please check the chat or comment section, excuse me, for the link to complete the evaluation.